Okay, welcome to the NOA webinar series. I'm Cormac Kelly. I'm your host for today, and this is the 13th, I think, webinar in our series now, our monthly series. And over the next 2 months, we're concentrating on integrated care systems, how it's going to affect the musculoskeletal pathways. And today, we're very lucky to have Andrew Bennett and Rob Hurd from the ICS in North Central London to share with us and discuss some of the aspects of ICS and how it might influence orthopedic care over the coming years. So let me get my page down. So just to remind people that the webinar is being recorded, everybody's on mute, but you can raise your virtual hand to ask questions, and please do. Any technical issues, go through to use the chat feature, please. And we've got the team in the background to try and help you out if you get into trouble. So just a little news update. So vaccination successful, we know all about that, but the Delta variant is spoiling things. So we know about the 4-week delay to opening. Since my daughter is getting married on the 26th of June, I'm particularly delighted that there's some special allowances for weddings. So that's the good news. The societies, including the BODS, the Hand Society, BOA, and other subspecialty societies, have issued their Caring for Patients, which was just released just after the May webinar. And that includes lots of stuff on how to take care of our patients during this pandemic and our responsibility and roles in communicating with them, but also assessing harms and in prioritization. Interestingly, at the British Orthopaedic Directors Society, we've got an extremely useful BODS chat on which we actually share issues around the country. An ex-president of the BOA asked very simply, how are you doing on recovery of elective orthopedic surgery? And there was a great variation across the country. And I just put together some of the comments about factors that influenced recovery. And one of the issues is some of the hospitals haven't really recovered yet from the shift of trauma and the so-called land grab from intensive care and emergency departments. Social distancing in theatres seems to be an issue. So if you had 10 theatres before, many people are saying that we're not back to our full 10 theatres. We're still working on 8 or whatever. Theatre staff, a big issue, especially with the variant out there and families having to isolate as the testing is extended. So that's a real issue. Very worrying in one particular area, there was no meaningful return to elective orthopedic recovery. That really shocked me. But my understanding is this is being resolved. In the outpatient setting, social distancing, it's putting patients in a waiting room now. There seems to be some let up in virtual clinics now. Some people have sort of gone back to their normality, and there appears to be a reduction in the number of people who are engaging in virtual clinics. Maybe because they feel they want to get back to their normal, but that was an interesting comment. There's been a lot of reconstruction apparently during downtime, so people are repairing floors and repairing roofs on theatres, and sometimes, as we all know, these things overshoot. That seems to be an issue in some trusts as well. Pre-op assessment, we've got a problem with pre-op assessment. Lots of people are going to virtual pre-op assessment. So you may have pre-op assessed this patient 6 months ago, had to cancel them, and you need to go there again. But the virtual pre-op seems to miss things like recent medical problems. And you don't always collect all the information at a virtual pre-op, and that seems to be an issue. The face-to-face has dropped off considerably compared to pre-COVID levels. But again, this is this is very, very variable across the country. So the topic today and next month is integrated care systems, and we all know a little bit about this, the white paper in April, second reading coming up in August, I believe. All of this coming into law in April 2022, and this has been called the most major shakeup of the NHS in many years, and I think I've heard that terminology before over the last 30 years. But certainly they want to concentrate on care up front, making sure it's fair and equitable across your counties. So a lot of good stuff in there, but a little bit of concern that we will hopefully discuss today. There is some flexibility in what happens in different areas. I think that flexibility can cause some issues as well. Again, we'll have some questions around that. And issues around governance, who's in charge. The biggest criticism by some people is this, again, privatization of the NHS through the back door? And I'm sure we might have a question on that as well. Some comments from the BOA only this morning, just referencing, first of all, the Queen's speech and the fact that we're bringing forward sweeping legislation. And in the background is a lot of staff, both doctors, nurses, healthcare workers, who are still a little bit exhausted. Their brain is exhausted, physically exhausted after the effort over the last year, and how people are going to feel. So we will hear a bit more about that from the BOA in July. So on that note, I'm going to switch straight over to Andrew Bennett. We got you eventually, Andrew, and I'm delighted that you can join us. And as you can see from his title, Andrew is very much involved in MSK, what's happening now and what might happen in the future. And hopefully he might have some idea how ICS may influence things moving forward or not. So I'm going to stop sharing my screen now, Andrew, and I'm going to hand over to you. Okay.
Yeah, sure. I will just share my screen. There we go. Is that clear?
Looking good. Thank you.
There we go. So, yeah, look, thank you for the introduction. So my name's Andrew Bennett. I'm National Clinical Director for musculoskeletal conditions with NHS England and Improvement, and that's about 60% of my time. And then 40% of the times I am a consultant physiotherapist based in Sutton Health and Care in Southwest London, affiliated with Epsom St Helier NHS Trust. And in that job, very much at the centre of how the PCN, primary care networks and integrated care systems are evolving, especially with a sort of place level focus within Southwest London. So thanks for the opportunity to come and speak. And I think I was going to talk very much about, set the scene about where ICSs fit within our Best MSK Health programme, very much in the context of restoration and improvement. But before that, I also just want to acknowledge, I was due to present in November last year around change, challenge and beneficial changes, which is very much still alive as a website, although we're not promoting it anymore. Interestingly, we're still having a lot of visitors and we're using it to share examples of good practice and changes that have been rapidly introduced that are working well. But unfortunately, I had to drop out very much at the last minute of presenting due to a family emergency. So just to thank the team for their support on that, and apologies, but it's great to come and speak now. So look, if we think about Best MSK Health, we have a mandate. So MSK is in a very different position to where it was this time a year or two ago. Essentially, through the 2021-22 operational priorities linked here, MSK has been mentioned as one of three main clinical specialities where there is scope to improve performance and value to reduce variation in access and outcomes. And what this has meant is that MSK has a lot more attention put on it within NHS England and Improvement, and we have a lot more resource to be able to do what we want to do. And through that, we have the Best MSK Health programme, which is part of the National Pathway Improvement Programme, sitting in NHS Improvement, and working alongside similar programmes in cardiology and eye care and urgent emergency conditions. So the vision for that programme is to enable best lifelong MSK health in all communities. And there's a lot of buzzwords here, but essentially our aim is to sustain delivery of evidence-informed, personalised, high-quality healthcare, integrated healthcare valued by all. And we really have a bilateral challenge. Pre-pandemic, we had significant challenges across MSK. We had increasing demand, challenge capacity, increasing complexity associated with lifestyles and population changes. And I think it's fair to say a variation in commissioning and service provision, which is resulting in a variation in outcomes, access, and driving health inequalities. Then as a result of the pandemic, we had to focus on supporting surge capacity and reducing transmission whilst maintaining urgent emergency pathways. Through that response, we've had unwanted outcomes. And one of those is the significant increase in the elective waiting list. Along with that, I think complexity of presentations has increased, and I'll come to that a little bit further down the line. And we've got as recognised by Cormac, we've got a workforce as well as a population that are significantly fatigued and have been through a significant experience. But through that, we have an opportunity. And during our response, through the sort of ethos of integration and collaboration and co-production we developed, working very, very closely with our arm's length body colleagues and also our stakeholders, inclusive of the BOA, we can take that forward through the lens of restoration to not only try and restore services, but do that through improve quality and value and improve and transform our delivery. And that's our opportunity, but that's on a current sort of scenario of complexity, as alluded to earlier. We've got to balance response, vaccination, restoration, improvement, restructuring, new ways of working, and our own well-being. And so it's a very complex scenario. So what's our objective if we focus on 21-22? Well, we want to build on what we've learned during the pandemic to transform the delivery of MSK services and accelerate the restoration of elective care. And that is our primary objective within the Best MSK Health programme. But of course, there are other significant challenges across the healthcare system. And we have a significant scope to help support primary care capacity, as well as community care capacity and urgent and emergency care capacity. And integration and across a delivery model is sort of the key principle underlying this. And this then relates to the development of ICSs. So if we take the principle that musculoskeletal conditions are essentially driven by pain, pain is driven by multiple factors across a biopsychosocial framework, we need to take a population health approach to MSK, especially because the vast majority of MSK patients do not need to go near secondary care and can be managed very, very well in primary and community care. Those who do need to get secondary care, we need to ensure that the right triage is in place to get those patients in an appropriate timescale. And we need to ensure we have the wraparound rehab in place following procedures to ensure patients can get back to what they want to do. Now, again, based on the principles of the biopsychosocial framework and the multiple drivers that drive painful conditions, we have to work in collaboration with health, mental health, social care services, and the third sector to deliver this. Not to mention that certainly in primary and community care, as in other aspects across delivery, workforce and capacity is a challenge. But we want to take this integrated model built on a population health approach, accepting that there should be a heterogeneity in local population in delivery based on local population needs and resources, but not accepting there should be heterogeneity in outcomes and access to try and enable best MSK health, which can be described as growing well, working well, and aging well. So if we then look at the ICS system, how does this map to that? So this is very much reflecting our MSK strategy. But essentially, we've got the wraparound integrated care system, which balances physical health, mental health, third sector, and social services in line with the principles of triple integration. We've also got the emergent primary care networks, where GP practices can work collaboratively to also review local population needs and commission resources accordingly. And how that's key to the MSK strategy, which requires collaboration between primary, community, and secondary care, is place level integration often through a community MSK hub. And through that, we've got the challenges of elective restoration, outpatient restoration, diagnostic restoration, and then the opportunity of improvement. This is not restoration to where we were before. This is trying to improve services based on the beneficial changes we've had over a very, very challenging year. Now, within that, we've got a linear hospital pathway and a whole pathway approach, which is the focus of our mandate within the 2021-22 priorities. How can we balance the pre-hospital, hospital, and post-hospital needs to help deal with these restoration and improvement challenges? And so this is structured in a collaboration between the programs, so Best MSK Health, and the high volume, low complexity work being driven by GERFT. And there are two real approaches to this. The high volume, low complexity work is very much focused on secondary care and contributes to elective recovery by trying to create capacity, optimize productivity, whilst also ensure value and quality. The end-to-end pathway work reflects this principle across ICSs of triple integration to say, okay, well, we can't look at MSK in silos, because if we do, we're not going to be productive. Actually, we've got to think about how we manage patients pre-hospital, hospital, and post-hospital to give us the best opportunity to create capacity and be as productive as possible to deal with the challenges we have ahead. And so how does that look for MSK? So pre-hospital, we've got triage, and there is the first contact practice agenda being driven within primary care networks. And we've got single point of access services being driven at a community level, and they need to integrate. We've got advice and guidance resources, but also we need to think about supported self-management. And we've had, to be fair, quite a big focus on triage over the last few years. But really, for me, one of the cruxes to this is to support the majority of patients who don't need interventions, who need a biopsychosocially driven, personalized self-management strategy to get that in primary and community care. Then, of course, we've got the whole high volume, low complexity work sitting in the hospital setting, very much with a focus on elective recovery, but we also need to think about outpatient recovery and diagnostic recovery. Then we have the rehabilitation challenge. We don't want to accelerate delivery of procedures and not have the rehabilitation in place to ensure we help patients recover well. On top of that, we also have the challenge with regard to waiting well, associated with elective validation, the length of the waiting lists, and supporting patients who are waiting for procedures to manage symptoms, but also get in the best possible condition to get the best outcome from what they're receiving. And this is really an integration not only between our program, but also between personalised care, outpatient transformation, and the elective care programs, working very closely with the primary and community care programs. And what I see Best MSK Health is that collaborative approach to bring these strands together. Now, in terms of that whole pathway approach, we're splitting the pathways stratified according to urgency into elective orthopaedics, spines, rheumatology, and falls, fragility, fractures, and osteoporosis. And I'm sure many of you may have been involved in the work that Tim has led around these pathways in orthopaedics and our respective GERF leads in spines. With regards to falls and fragility fractures, that sort of borders our sort of envelope of work in MSK. Obviously, there is an overlap with the trauma work group, but it was felt that this sits well in this program, and this hopes to take forward some of the excellent work done in the past, but also integrate with community services and the frailty world. With that, and with those pathways, we need to enable them. So we need to link with primary and community care, but also the other key enablers are diagnostics and the long-term condition management piece. And we've got specific work streams focusing on primary and community care delivery and long-term condition management. But the ultimate aim across that whole pathway and that sort of linear approach is to manage risk, demand, and capacity to deliver high quality, high value care. And we have to do that through integration. And of course, this is a very linear hospital pathway. But if I come back to this slide, that integration needs to link with mental health services, social health services, and the third sector. And really, my perception of ICSs and indeed PCNs and the evolution of sort of place-based work is to provide that vehicle for integration. So what is our strategy within this program moving forward? Well, we have focused priorities They are restoring integrated high quality primary and community care to optimise referrals, enable rehab and long-term condition management. And I would also add prehab into there in terms of waiting well. We need to use the GIRFT gateway metrics and best practice resources to transform and optimise elective and orthopaedic spinal procedures. We need to ensure timely pathways for core rheumatology conditions, and we're implementing end-to-end pathways for fragility fractures. And this sort of Venn diagrams, it gives an example of what, it gives a strategy of how we're trying to do that. So we're putting together some high impact recommendations across those pathways now, which will be underpinned by a series of metrics to measure impact. And will be linked with the pathways that are already being developed through GIRFT, but other pathways which are in progress. And then the supportive strategies related to primary community care, diagnostics, and supportive self-management are very much involved in the other programs of work linked with ICS development within those domains. So the diagnostic recovery work, community diagnostic hubs, first contact practice work, and the personalised healthcare agenda are all engaged in or engaged with work streams in that field. And then we need to deliver that. And how we are looking to deliver that is working in collaboration with the regions, then with the regions through the ICSs to build an MSK network of MSK leads at regional and ICS level. And the role of those leads is not to take a square peg into round hole approach. It's to evaluate population need and resources around principles that we are developing to adapt and adopt those to meet local needs. And then underpinning that, we've developed our future site, which will be a community of practice for the MSK world, where we want to, similar to Change Challenge, and really the next step from Change Challenge, we want to share what works well with other leads. And what we don't want to do again is say, this works well here, do it exactly the same way you are. It's about the principles that made that work well to translate into other services. And so we've got a significant challenge ahead. We had a significant challenge when I was new to role as MSK NCD, and that significant challenge has been catalysed and grown significantly in the context of the pandemic. But we do have an opportunity. We have an MSK programme and all the resource that brings. We have a focus across MSK. We've got work streams and program leads who are working really very hard on bringing this work together. And I think through an ethos of integration, collaboration and co-production that we have developed in response to the pandemic, which is very, very strong, I think we have a massive opportunity to drive improvement in quality and value through restoration. And so the opportunity that is there despite the challenge being very significant. And that's me.
That's great, Andrew. Thank you very much. Just one little thing before you talked a lot about supported self-management.
Yeah.
There's been a lot of criticism around virtual physiotherapy. So I asked to see a physio. They would only see me remotely over the phone, and they emailed me some bits of paper, and then nothing happened after that. How do you support self-management? What are your recommendations?
So first and foremost, we were in a scenario over the last year, as other specialities were, where we couldn't do face-to-face work. And in terms of rehabilitation and self-management, that creates a significant problem. And we rapidly, and a lot of services, to variable success, rapidly introduced virtual consultations. Now, that is not the future in its entirety for me. The future is being as accessible as possible through a shared decision-making process, making the best use of resources we have. For some patients, virtual consultations and guidance, advice and guidance works very, very well. For a lot of other patients, it doesn't. So we need to have a model where clinicians and patients can agree the best way to undertake the consultation and deliver that. We also need to ensure within that model that in terms of productivity, virtual consultations are not viewed as quicker. And that is always a risk. And that is something we are very much saying that we shouldn't do. So we are welcoming the introduction of virtual consultations, but through the lens of the patient and through the lens of what is the right means of consultation to get the best outcome. Now, also physiotherapy, and obviously I'm a consultant physiotherapist, physiotherapy is a big part of that, but so are other elements within primary and community care. We've got to make best use of the third sector. We've got to make best use of personalised care resources. And we have to do that simply because of the challenges associated around capacity. But essentially, one of the challenges in supporting people to self-manage or rehabilitate is sometimes motivation. And that motivation comes from many different facets, but one of them is having the resources that are accessible and having a way of doing it that people want to do. So what we've got to do is we've got to have a suite of resources that are available locally, that can be accessed by patients to inform their rehabilitation and long-term condition management. And that's got to be done in a sort of bespoke approach that incorporates all forms of access in the right way that is determined through shared decision making.
Okay, so it's really about patient choice.
So it's about patient choice, because of course, if we're going to enable best MSK Health for all, the patient has to be at the centre. It's also about making best use of resources, and it's also about clinical expertise, and that's the underpinning principles of personalised care and shared decision making. So it's about the clinician working with the patient to work out the best way forward. What it's not about is, right, we need to do everything virtually now. That's absolutely not the case.
Or the opposite, the pandemic is over, we need to see every patient.
Absolutely.
And
absolutely.
that's a big problem we're having in outpatients. A lot of patients say, I'm done with this virtual thing. I want to see Mr. Kelly.
Yeah.
Okay, Andrew, there'll be lots more questions, I'm sure, over the next half an hour. I'm going to switch straight over to Rob, get the opinion on the secondary care side and the ICS. So once again, welcome, Rob.
Thank you, Cormac. Can you just confirm you can hear me?
Yes, I can.
That's great. So Andrew and I didn't plan this, but I'm attempting to follow up from that very valuable context that Andrew's just presented. With my aim really here is to give turning some of the theory into practice based on my experience of being the North Central London Integrated Care System lead for the last 15 months. I know many of you know me already, but by way of introduction, I was Chief Executive of the Royal National Orthopaedic Hospital for a number of years prior to this secondment that I'm on at the moment to the system. And what I'm trying to do is spend 20 minutes just talking through turning the theory into practice on the purpose of ICSs and some practical examples of what we've been doing and are doing in North Central London. But I want to pose sort of two questions at the start and come back to them at the end as I'm talking through this, because a lot of this, when we talk through these long slide decks and come up with diagrams and things, to keep it real, if you're all thinking in terms of how does the health and care system feel to MSK patients, how they experience that in the past, how they've experienced it over the last 15 months and how we envisage their experience in the future. And then translating that into what on earth does all of that mean in terms of this yet again another reorganization of the National Health Service into how we do things, and then more explicitly, what on earth does that mean for us and what's in it for us, and what we make sure that we align all those three things, around what we are ultimately trying to achieve with integrated care systems, with what the people providing those services are aligned with that vision and how we organize ourselves. And there are many unanswered questions around those three questions, but if we have those in the back of our minds as we go through. Second point, I wanted just to acknowledge that a lot of what I'm presenting is nothing to do with me. It's the work of some fantastic people we have in North Central London who brought a lot of these new ways of working and work in progress for our residents and patients together over the last 12 months. And I'll be talking a little bit about these practical examples, the practical example of us as an accelerator system at the moment on elective recovery, the practical example of the orthopaedic review that's taken place over the last number of years, and the practical example of the work that's taking place on inequalities as we recover from the pandemic go into the future. And then to acknowledge up front that there are some of these unanswered questions, one of which is, what is the unit of planning, what we are trying to achieve as an integrated care system? that is very much, as Andrew's been talking about, very much about the population health-based approach, about local populations. But that given the different types of systems you work within across the country, there are many examples where that's a bit blurred when we're looking at if we're focusing on local residents versus residents that come in from outside of the area, specialist services, interdependent services, as we look at any given pathway. And there are a whole range of complexities. But the challenge back I would give is that if we come back to my opening question of how does the health and care system feel to our residents and patients, if it is not joined up and not integrated, and it's not that holistic experience for our local residents, then we're failing in addressing the issues of care and health in our system that we're doing. And there's no reason in theory why the previous mechanisms of the internal market, the promotion of competition, should not have been able to address these issues. But I think we live in a world now where it's acknowledged that that isn't going to be the answer, whether we agree with it or not, for the period ahead. And we're organizing ourselves differently, and that is a fundamental culture change. And finally, before I launch in, just acknowledge, this has been a really tough period, and our workforce well-being and the experience. I talked about the experience of our patients and our residents, but clearly the experience of our workforce and the challenges around our workforce and the exhaustion and also the uncertainty around the future and the marathon of sprints that we've been in. It's not a marathon of sprint, it's a continuation of constant marathons in dealing with the pressures across all our systems that everybody is under. So having acknowledged all that, as Andrew said, I mean, ultimately we can refer to the national communications around the purpose of integrated care systems, the triple aim of improving health outcomes, inequalities, and the wider economic picture and interdependencies. But in talking to our residents in North Central London, we've translated that in terms of a more detailed picture of a vision for start well, live well, age well, and fundamentally in our anchor institutions with our population of 1.5 million, when we're employing 100,000 of health and care staff, fundamental to all of this is those anchor institutions as employers and the economics around that as an important component, and to make the work experience in the National Health Service in North Central London as positive as possible in the challenging environment we work within. So this is just by way of summary of saying we know health and care isn't just about what we do in hospitals. We know it's a wider range of determinants of population health, and we also know fundamentally that we have significant inequalities in population health outcomes. We have significant inequalities in access to health and care, and we have significant inequalities in the outcomes for health and care. So that's why integrated care systems exist, to challenge that in ways that to date previous mechanisms are not deemed to have taken on those major population health issues and inequalities in the past. Specifically, I mean, I've got 62 slides which will be shared with you if you read in detail, which I'm going to rapidly just pick a few bits out, because I think in terms of sharing what we're doing, it's probably best if we share the detail, but I just pick out some of the headlines. So yeah, that's what it's all about. Our aim is to improve outcomes for local people, reduce health and care inequalities, and support our staff to work well. We translated that into a number of very specific aims that we're working on as a system, and all of these will have strands towards, as Andrew's been alluding to, in the MSK strand. So I want to rattle through to a bit more detail, but that we have a whole population health life course. We now have immensely rich and powerful health inequalities data, population data, demographics around outcomes from the whole life course of treatment, right down to borough levels and individual ward levels of what our residents are experiencing from the health and care system. And we know wide variation, to pick out the MSK example, of those living with pain and musculoskeletal conditions, ranging from 15% to 30-something% of the whole population was affected by MSK and pain and interventions in that pathway. In headline terms, therefore, that's what we're about. We're improving outcomes, acknowledging that in some areas, although this is all about the place, we cannot have the place, the borough, the local ward having every aspect of health and care provided locally. So as much as possible is provided locally, but there's a need for economies of scale. There's a need for things to be brought together at scale in order for us to sustain a workforce, sustain efficiency and effectiveness, and to sustain best care for our local populations. And that can't be replicated in every high street, in every part at a local level, and requires some form of scale of provision of health and care services to deliver best outcomes and reduce inequalities. But it does mean new ways of working, and it does mean that we ultimately still have to have a self-sustaining, self-improving, self-governing, population-based integrated care system, and with MSK conditions as a significant chunk, as I've just alluded to, as part of that population. So then, with my overall aim of sort of bringing this down to earth in turn, and so many of you will have seen some of this, but I'm trying to put in context the sort of thought experiment of what we do differently in an integrated care system world than we would have done in the past. And I think that we're slightly in different phases here, aren't we? Because there's a sort of pre-pandemic world, there's the work that's gone on in immense amount of collaboration and mutual aid during the pandemic, and partnerships all over the country, and having to respond to the situation, which has been different to what came before the pandemic. And then there's the sort of transition through recovery into the future state. And I'm trying to explain, when I'm going through things that you will have heard before around things like consolidation of elective centres, hot and cold separation, GIRF principles, etc., why I would propose that the system working element of this, in terms of that overall aim as to what it feels like for patients, is different in an ICS world to a provider competition world. And by way of example, our elective orthopaedic network that we've set up, fundamentally the information that patients receive, if you live in North Central London, you get one set of information advice used across all of our hospitals. We have less centres providing inpatient orthopaedic care than we had in the past, in order to provide resilience to the elective centres. And so we have had to communicate, consult with the public, consult with the politicians, and have a full public consultation of the reconfiguration of services, and as well as you would expect, the engagement with clinicians and staff for these changes. But the entity that's done that is the wider system, not in any formal legal sense of having not been created yet, because the legislation isn't there till April to do it, but the coordinating resources of acting in the patient interest to do this, with the support of the organisations in that network, and fundamentally the fantastic work of the clinical network that we have in orthopaedics in North Central London, working partnership between the North Middlesex, Royal Free, RNOH, UCLH and the Whittington. And just by way of example, giving you that, so the information interface, the interaction with patients, the care coordinators that are built into the pathways, because the age-old question of people don't want to travel, and the inequalities caused by offering new pathways and different journey times, have all been tackled head on in this review, to ensure that we don't achieve centres of excellence with more inequitable access, with people struggling to travel there, but we do achieve the net result of an overall gain in the quality of outcomes, a reduction in inequality, and a consistent access to service that's not achievable through the fragmented landscape we had pre-pandemic, and have created over the last 12 months with ring-fenced facilities. So I mean, by way of background, I mean, the actual core of reconfiguration there, which actually has come at the right time for us in terms of responding to the recovery at this moment, began a number of years ago, but was subject to consultation, and the new model is now fully in effect at our elective high volume low complexity hubs, and the full pathway understood from primary care, consolidation of referrals. And I will talk later about how we've enhanced that through the system working in the shared patient tracking list and the shared working that we've got across North Central London. So fundamentally, it's about, as you will all be involved with, achieving that excellence in care, research and education, and has the provider partners at the core of that, and the clinical network at the heart of overseeing that partnership and its effectiveness. But it is backed by hard contracts and the expectations of our commissioners, and the public and the local authorities and the residents that we have consulted and implementing a model. So it has that full range of support. It is not just a fully needs must response to the pandemic side of things and doing reconfiguration under the cover of COVID. It's had a wider consultation and involves the partnership working between those organisations, and ultimately, as I say, is creating hub sites at Chase Farm, at UCLH, and supported by the RNOH as a specialist centre working in partnership, particularly in the north with Chase Farm. So the idea, you'll all know this: improved education, appointments with a named surgeon, rehabilitation, access to high dependency, getting the complex work addressed as well as the routine work, and the key issues around high complexity, low volume work as important in some of these pathways as the low complexity, high volume work. So with these slides are by way of just explaining that the work that's done to explain to our residents and to across the clinical pathway the translation of those best practice pathways in GIRFT and a whole host of evidence that around how those work to actual sort of practicalities of which hospital you see who, where, and how the pathway works, and care pathway coordinators in place to support that, and the public consultation, very much how long you're going to have to wait, the familiarity of clinicians and their local hospital, and the importance of local care where appropriate, but also an acceptance if it's clear that you might have to travel differentially from historically to a smaller number of centres doing the inpatient component, and that's just providing the pathway at a glance. I then wanted to build on that, having sort of established, and I just basically say that under an integrated care system, that type of partnership working that is the type of thing, a type of example of that network across all, so population focused as opposed to organisation focused, collaborating multidisciplinary teams with the workforce and patients at its heart are some of the fundamental principles that integrated care systems create the conditions of success for, that perhaps we didn't drive as much in a competitive PBR environment of individual institutions competing with each other. And then to give another example of how we've responded in North Central London to the pandemic recovery, we have the example of the accelerator schemes. So we're the London system for accelerating the recovery in orthopaedics, with an aim for getting, we were 95% of business as usual target. We now got 120% business as usual target on the terms of the volume of work that we're doing for the end of July. We think we're in a reasonable shot, and in full acknowledgement of workforce well-being, extended hours working challenges, and the challenges of staffing the vaccination programme, staffing the ever increasing pressures in primary care for a whole host of reasons, and the almost winter pressure, or exceeding winter pressures, urgent care pressures that we seem to have at the moment, and balancing all of that up, but as far as possible keeping the electives going through those hub sites, those green sites, those separate sites, in an accelerated way. And I'll be talking a little bit about what the sorts of things we're doing to support that. Again, in full acknowledgement, this isn't me. There's a whole host of really good people leading on this implementation and doing some really fantastic work in this area. So we're aiming to get to basically up the activity, but do not be under any illusion that upping the activity does not just mean extended hours working and item 1 on that. It very much also means items 4 and 5 and other primary care, community care, rehabilitation. So we've got a real focus as a system on understanding all elements of the pathway to tackle this, because I'm fully aware that the 31st of July is the target for the accelerator system, but there is life on the 1st of August and for the many years ahead, where we are going to face significant MSK demand and capacity imbalance, and new ways of working are going to be fundamental. So although, yes, this is about extended hours and getting through more work in the short term, it's equally and more importantly about what the learning around how we do that is for a more sustainable outlook into the future. These slides are just giving you some picture of where, as I say, moving from where we were heading for 93% to 120%, with all the risks around workforce, with all the risks around third wave, etc., but feeling that we could uphold that as long as the surges were contained within reasonable levels, but there's a whole host of risk around that. So yes, first example is the extended hours working model, and yes, we have had to agree pay rates, a pay framework around extended hours working model. We have had to grapple with the issues of some fantastic work around mutual aid and what happens when you move staff and passport staff across and patients between different institutions. As I say, the learning of why I started with the orthopaedic review, building on some of the learning that we've had of acting as one system and not a series of different organizations, so that passporting workforce, moving workforce around, moving patients around is part of that, but moving those patients to particular hub sites, which will be core to the volume question of getting through the work and applying GERF principles and the best practice pathways that we've described. So we have extended hours operating models for the weeks ahead being implemented in all of these centres. And of course, we are then, this is just another moving staff around. Now, the learning of perfect weeks and blitzes in activity, etc., is actually the administration, the operational side of this. So you need the clinical leadership in place, you need the joined up work, you need the culture of the focus on the patients and the inequalities and and the access issues that you've got. But of course, you also need the operational, the administrative infrastructure to make that happen, because it doesn't logically happen in the setup that we had in the past. So you need specific initiatives that are very detailed, to use the horrible word, granular level of working that through operationally and having an ability as a system to do that. And that's fiendishly complicated given all the pressures that we're under, but we are setting up the sort of dedicated outsourcing team, dedicated facilities to make some of these things happen more smoothly than they necessarily have in the past, if at all. Independent sector is critical to that. Again, we have independent sector capacity, and I know you will have many examples of it's all very well, but the staff is the constraint. However, there are also ways in which we jointly manage with the independent sector the staffing pressures that we have to ensure that we are making the best use of that precious staffing resource and the capacity that we have in the independent sector. And crudely speaking, we're changing the model from, you know, trying to book the independent sector on a Tuesday afternoon for patients X, Y, and Z, to a much more, they're on the PTL, joined up with cohorts of patients, we're stratified with one patient tracking list across the population, and are there cohorts that we need to work in partnership with local independent sector providers, that they're part of the network, they're part of the whole picture, and it's less of a contractual case-by-case basis with poor utilisation and arguments about where staff can go, and more of a partnership of a collaboration for a cohort of patients to act upon over a period of time. And demand management, you know, trialing more and more expansion of clinical advice and guidance, and as you've just been discussing, digital telephone platforms, and trying to support GP colleagues as well, who are under massive pressure at the moment, to what the best source of support and guidance is out in the community and in primary care and at a local setting, to reduce the onward referral and for people having unnecessary contacts into secondary care. One of the things I think we're probably most proud of is in all of this, the bringing together of the waiting list and then the inequalities analysis that we are more and more being able to do, where we can really get to a level of how is, going to my opening question, how is the population experiencing MSK services and what are the, you know, by individual road, ward, borough. We can track local populations and ethnicity, deprivation levels, and how they access and how they appear on the waiting list, and getting all our hospital waiting lists in secondary care and tertiary care into one place, linking together the primary care data, get the secondary care data, tertiary care data with the population health data that we hold, and in partnership with local authorities, so that we can use this in the same way that all of you will be doing in your health economies on vaccination implementation, and using that in real-time data to understand the inequalities in the waiting list in all its forms, and through systematizing our patient tracking list from a number of separate hospitals with their own waiting lists into a more systemic view of the access and the waiting list. Which includes significant proportions of residents from outside of North Central London, and how those are reviewed at clinical networks, prioritised, informing decisions about how processes work, and also keeping an eye on the inequalities of that process. Key to all of this, mutual aid, just keeping an eye on time, the whole set of fantastic work that's been taking place on getting into the detail of what are the blockages to mutual aid in terms of moving patients around to the best place and making that as smooth as possible, and showing many thousands of patients examples we now have who are being treated in different centres and different locations than they would have otherwise have done, and indeed being treated quicker as a result of that compared to the service models that we had pre-pandemic. These are probably known to many of you as some of the principles we had in London that were agreed a year ago about how our mutual aid processes should be working. I wanted to build a little bit on so inequality is the heart of everything we do, and inequalities in musculoskeletal health is stark as well when you look into some of our population health data and access across all those outcomes and access across all those domains in inequality I talked about. So I just wanted to pull out this slide. So we now can see on a live basis what appear to be the determinants of how long you wait for access, and clearly the predominant access inequality, if you look at the headline numbers, tends to be the organisation to which you are referred. And going back to the orthopaedic review, so depending which pathway you embark upon, the biggest correlation with the length of wait and access will be which pathway you have been set upon in the first place. And if you are ending up at the Royal Free, for example, as this, that's the big, apart from the unknown item at the end, which is interesting in itself, as one of the biggest determinants of the length of your wait is if we don't know any information about you, you're likely to be waiting the longest time. But if we know something about you, we know that where you're referred is the longest, means your access will be the most difficult. But then beneath that, some really stark data around least affluent, so waiting the longest, and actually young people in North Central London having there's a correlation between your age and weight, and obviously that's to do with the way our paediatric services and belonging capacity issues differentiate from adults. But I just use that by way of illustration of the type of things we now look at, and a type of example of what the ICS level is doing in terms of informing how we organize ourselves across providers, etc. in the future. And of course, in primary care land, we have all our analyses of why the referrals appeared to drop down, but we all know that the underlying need is still there. And so how we target our approaches to responding to the fall off in referrals, which are obviously coming back up, but the causal factors of those are important to inform how we're responding as a system. So ultimately, you know, we've got linking the primary care, the secondary care at an ICS level, genuinely bringing together single sources of referral management systems, first contact practitioners, working in the community and out in primary care networks, etc. But also that transparency, that visibility of the data and the inequalities in the data as a drive, going back to Gerth principles of that clinically led but data driven approach to how we deal with things. And again, this is all sort of some fairly dry slides around how we organize ourselves, which I thought people might find useful because it's not words, it's actually the things that we're actually doing. So we have an overall recovery program, we have a whole infrastructure, how we organize ourselves, so it's not all the different providers as we were organizing themselves differently. We have system-wide operational implementation group, we have a whole system-wide set of networks. So I'll come to this last point. So within the overall North Central London population system, I chair the system recovery executive. Matt Shaw is chief executive, Great Ormond Street, chairs a fantastic group, an operational implementation group, which brings together the operational leads. We are advised by a clinical advisory group, and we have networks, and the orthopedics network you'll see is a key part of it. So the message I'm trying to give is this is a fundamentally different way in which we are organizing our response to provision of health and care. There was some comment talking to Cormac that's so interested about what we've been up to on our pay rates, because I know one of the key challenges of workforce equity and well-being, we've agreed some principles as a system around that, and I won't go again, I've got time to go through all the slides, but we have some sort of fairly key issues around how we uphold equity, staff well-being, how we acknowledge the exhaustion, how we acknowledge there are tax and pension implications, how we acknowledge there are equity issues about what did we pay during the pandemic for people who were working really, really hard and getting exhausted, and now we're in an electric recovery phase, and are we upholding an equity of approach to that? So we do not have, you know, harmonized bank rates and the same rates across the whole system, but we do operate within a framework, so there is no breaches in the overall framework of how we are operating as a system. It's something we are trying to uphold as a system, again in full acknowledgement that an integrated care system has currently no legal authority and currently has no real, I have no particular levers over trust boards as to how much people pay their staff, but there is that collaboration and they're looking at the market as a whole, and how we operate as a whole is something that the ICS brings together. So extra work, not exceeding the caps that we work within, and also you know, monitoring that locally. Transparency of the data is important, and being transparent also with other systems, because we all work within a wider health economy beyond North Central London, so we don't want to have detrimental impact on partner organisations beyond our walls in terms of whether we're paying excessive rates relative to them and causing bigger problems elsewhere. So what we came up with was not a harmonised rate to everything, but a set of principles, and keeping monitoring the impact of this under review at quite a detailed level, organisation. I will then shift on to so, you know, just completely acknowledge, because I get asked this all the time around the pensions issue, around different models of employment that are being set up around the country, limited liability partnerships models, etc. And there are a whole set of complex issues of that, and I'm happy to take questions on that without going, but I've provided some background detail for everything, for everybody to as a reference point for what some of the underlying reasons behind some of that are, and the complex tax arrangements and situations that lead to some of those situations. So this is just by way of sharing some background information to inform that, and then just bringing this to a close. That our place-based arrangements are fundamental. We have our partnership organisations, and those organisations, as I say, coordinate the activity of things, the setup of the more collaborative approach, the focus around bringing the different elements of the system together. And we have a provider alliance with all all providers, mental health, community providers, as well as acute, as well as a primary care alliance itself, which is on our provider alliance, targeted by the ICS with specific strands of work within this. So the whole area, our big strand of work is what's the clear blue water between what an alliance of providers does versus what an integrated care system does versus what takes place at a local place-based borough level. What we're doing is not trying to recreate clinical commissioning groups at a local borough, but the unit of delivery is around the population and the borough and the partnership, and giving delegated authority across that, working partnership with local authority, social care, and the different components. But acknowledging that the providers need to sit around that and provide at scale services to those local populations. So providers who are providing to more than one population, sometimes say, well, this is really complicated because we've got to service multiple local population borough-based arrangements. The counter argument being, as I said at the start, if we think about how we experience, if we're not organising ourselves around the local experience of health and care systems then what are we doing? I think I will, in the interest of time, continue to rattle through just to highlight financial strategy. So yes, finances is complicated. We don't know how much money we've got, you know, second half of this year, let alone into the future, but we have some very clear financial principles that if something is in the overall interest of patients and money, but that can't happen because one organisation theoretically loses and another one gains, we then have arrangements and signed off by trust boards to make sure that the impact of that is smoothed and planned for, and that what we're doing for the benefit of the things I've been describing is not held up because of the financial architecture is not in place to support the best thing happening for patients. I know the devil's in the detail on that, but that fundamental principle is different to one in which we compete and some people win and some people lose, and we hope that in the end the patients benefit. As Cormac alluded to, we're on a timetable to be a formal legal entity, and there's all sorts of national guidance and things coming out around this, but we are heading towards, you know, we're working effectively in shadow form, and our aim is to not create a separate layer, strategic health authority separate, but have the community of leaders that we already have participating in some of the things that I've described today, and that out of that comes a self-sustaining, self-overseeing, self-governing, population health focused system, that can deliver for its residents without creating extra layers and complexity. And this is information around what the specific areas are what we do at an ICS. We have a number of programs. We came out of our sort of gold, silver command level response to the pandemic, now with our priority programs around each of these strands and the interdependencies that we work through. And obviously with our MSK on being a key part of the elective recovery at the moment, but also, as Andrew was saying, the pathway work, the population side of that, feeding into each of the relevant work streams in here. Never forget workforce. It's all about the workforce. It's going to be all about the workforce, and will continue to be about the workforce for the years ahead. And that we should keep at the forefront of all our minds as in response to the inequalities and the significant access challenge that we will face over the months and years ahead. And digital, I'll just pull out there as particularly important. So I will pause there, Cormac, because I realise I've given people a lot of information, but I thought it was better to give people background reading rather than give some very high level bits of information. Thank you.
Thank you very much, Rob. Thanks for restricting it to 64.5 slides or whatever it was. You've given us a lot of information there to chew on. Can you reassure me that you seem in North London to be ahead of the curve as a so-called shadow ICS? Can you reassure me that other ICSs that are in the early part of the development, that this is all being shared in some way?
So yeah, I mean, for example, the accelerator, we're under obligations we have a learning partner. UCL Partners is formally appointed to be a learning partner, to publish information about that and to be shared widely as we go through, and that's along the way as well as the evaluation at the end of it. I hesitate a bit, Cormac, to respond to your question, because I wouldn't claim that North Central London is necessarily ahead of the game on all fronts. I mean, I'm obviously logically giving a spin on it as the system leader, you know, down in on the ground, and so there are a whole set of complexities that we still grapple with. But in terms of the setup of the way we've organised ourselves, I think we've still got a way to go on making this real and bringing our whole sort of constituency of both of organisations with us. But at a leadership level, I think we're making progress on that. In terms of what this means, what's the world look differently to an individual ward or operating theatre or clinician in our system, other than the clinical networks approach sort of described, which many people across the country have been doing for many years, haven't we? We've been doing clinical networks, and we've been working in partnership together. We've been having multidisciplinary teams, shared working across sites. So I wouldn't claim some of this is all new and wonderfully advanced in North Central London at all. I think it's building on many things, building blocks that many people have in place already. And perhaps some of this is just the good work of able to bring it all together into a pretty presentation or something, or too long a presentation. But I think fundamentally we're talking about the culture. We're talking about how we organise ourselves to respond to the patient and the residents in ways that was previously more organisationally driven, is now more system driven.
Thank you. So we've got 12 minutes for questions. I see there's 5 on the board, but I'm just going to start, Rob, just get the elephant out of the room. Biggest criticism of ICS and these new pay thing is that again, the private sector in through the back door. So in London Central, where do you see the private sector? I see some words like outsourcing of cases, less complex cases. Is there going to be licking of the cream off the top by the private sector here? What's going to happen, do you think? What's your...
So, well, I mean, I'll give a personal perspective. I mean, in terms of the orthopaedic review we did in North Central London, I was constantly amazed by, fundamentally, we were reconfiguring things that were potentially to the detriment of the independent sector. But during that period, I was constantly accused of this privatization by the back door. And I think what I would say is the independent sector has got to be and remains a fundamental partner. It's about the nature of that relationship, because we just don't have the capacity, and we need that relationship to be different to where we've been in the past. That means that we will continue to have, as we always have had, contracts, insourcing, outsourcing contract with the independent sector, I think, but they will be different to the traditional tender. I mean, in Girfton, when Tim Briggs and I went around the country, we had some real horror stories of how commissioners had done tenders and awarded work to independent sector, and people were competing in it, and clinicians and staff had not been involved, and all sorts of ways of not to do implementation of change through a contractual tender mechanism. I think this is signalling more flexibility around that, which I can understand, therefore people might be worried in a political sense. But I do think it gives the more flexible levers to not compel contracting tenders in ways that we have in the future if the legislation goes through and the consultation unfolds as we expect it to. Okay. So I think we're always going to need to work to partnership, and the independent sector is not some sort of evil entity in my view. It's a core partner to this. It's about the nature of that relationship and the nature of the things that we will not achieve on our own without partnership with the independent sector.
Private sector is here to stay to help the NHS out, but maybe in a different format. Yes. Okay, I'm just going to run some questions. Some of these questions are for both of you, but okay, anonymous. A recent NICE guidance on pain management recommends acupuncture for various pain problems in the NHS. What is your opinion on this and local implementation in an MSK pathway? I think that's for you, Andrew.
Yeah, so the NICE guidance recommends an active management strategy for persistent pain conditions. That means we have to flip a culture of management away from a task and finish approach to a long-term condition management approach. And that involves a multidisciplinary approach, largely focused in community care, associated with the multiple drivers across a biopsychosocial spectrum that drive persistent pain. Acupuncture has been included in there. It is a matter of debate. Personally, I think that it has to be accepted in that context that reliance on passive intervention is not the way forward. And if through a shared decision-making process, it's felt acupuncture would help, it has to be enveloped within a cognitive behavioral informed physical therapy, whatever we want to call it, but technique sort of strategy to support the other elements providing the persistent pain.
Okay. So we won't be seeing our end-stage hip arthritis getting acupuncture before they're referred to secondary care.
I'm not a fan of acupuncture on its own as a single intervention.
Okay, thanks. I'm just going to move a little bit quicker because there's a few more for you here. Use of Ellen Parr, do you use any digital self-care solutions to support patient prehab or rehab? We've actually had some information on this at the last webinar. And that's for you again, isn't it? Yeah.
Yeah, we're working very closely with NHS Digital. I was involved in a webinar yesterday presenting about the digital playbook, which goes through a lot of resources available digitally, which could be recommended for sort of translating out into practice. So we're very much exploring a digital approach, but not digital first. It's like the conversation, Cormac, we had earlier about virtual consultations. It's about the best use of digital with the right patients at the right time and balancing, those health inequality issues with digital, etc. So that is work ongoing, but it's not the be all and end all in my view.
Okay. Physiotherapists asked about cash in the ICS. In the ICS, any upfront based therapy? Will we get more cash up front for therapy? Is there more money flowing your way, Andrew?
So we've got more resource at a national level. I can't give a definitive answer on that. That's work ongoing. I think it's fundamentally up for the ICSs to evaluate their population and resources and utilise their cash in the right way to meet those needs. And that requires local leadership who can translate the principles we're talking about to the local area and use the cash wisely.
Okay. I'd just say on that, Cormac, that, without being able to respond specifically on the individual issue, that the fundamental sign up of our acute hospitals and our local authorities and our politicians and everybody to be that money needs to move up the pathway, community, primary care, and we've built enormous hospitals that now are not, you know, so, and that people in hospital land believe as well. So that is going to happen. It's a fact. It's a fact of like that. How quickly it happens, because that's how the inequalities are going to be dealt with and how we're going to deal with some of this. We need to invest up the pathway, and our ICS has got it at the core to its financial strategy to do that.
Okay, I suppose coming from secondary care, I just wonder, as it comes up the pathway, how much money is left by the time we get into secondary care.
Indeed.
But I think that's a discussion for another day. There's a few questions here again about the private sector. Surely if the private sector is involved in the ICS pathways, there will be competition by providers, something the white paper says it's determined to eliminate.
So
right.
Competition between the independent sector, is that what
yes,
you're talking about?
I think that's
what so it's a different, so if I go back, if we're saying the network looking after the population is multidisciplinary, yes, there might have to be some competition for on which network, who's the lead independent sector provider doing that. So yeah, that's because that's law, public sector money going into somewhere else. There does need to be that there will be that competitive element still in the system.
Okay, and sort of associated that, Rob, you say private providers for NHS activity. How is that working, and what is the local plan to include the private sector in decision making at ICS level? And I think there was private sector in your slide there somewhere.
Yeah. So I mean, in a future state, I would envisage, having cleared the competition issues that I've just alluded to, each network, the private sector are part of it, and that will be different in every single network depending on and it might be, God forbid, that the lead provider for a particular pathway is an independent sector provider working in partnership with the NHS. It might be that the one independent sector provider who's an elective doing elective orthopaedics is sitting on the network. What I would say is that in the past, we've had not transparency of the information. We haven't had the clarity on the waiting list. We've had the direct commission referral. What we now have, as we sit here now, is that information in one place. We know what's going on in the independent sector, and we know what's going on in the NHS, and we have networks that can look at that information to decide on the best model of care. So it's a different type of setup.
Okay, another one for you, Andrew. MSK pathway makes total sense. And as a physio who manages an MSK service, this is great, and it spreads the physio role across all stages. However, with FCP roles being established, this is starting to destabilize the system with staff movement. Are HEIs being encouraged to increase numbers, being trained to meet this demand? I think that's for you, Andrew. I don't know what a HEI is, but you'll be able
So HEI is higher education institutions.
Okay.
So look, so we've got a challenge in primary and community care of balancing triage with long-term condition management and rehabilitation, essentially. FCP mobilisation was an ambition of the long-term plan. We've changed that a little bit to integrating FCPs based on population resource and population need and resource. And what we've got to do is enable local leads through this new ICS and PCN strategy to actually make best use of the workforce available to deliver the right sort of triage, whether that's using a single point of access service or an FCP service. Now, we've got a broad challenge with workforce right across primary and community care, like we have right across the pathway. There is a time lag in terms of recruiting new workforce members. And of course, the numbers are increasing, but we've got to account for that. We've also got to make best use, not only the independent sector, but the third sector. And personalised care resources, social prescribing resources to help support the primary and community care challenge. FCP is part of that strategy, but it's not the strategy. It's a multimodal strategy linked with the ICS and PCN agenda.
Okay, thanks for that. It brings us nicely to the end. I'm just going to share my screen if that's okay. Back to here. So in summary, I just want to say, first of all, thank you to everybody who participated, asked the questions, but in particular to our two speakers today for giving up your time and being quite comprehensive in your responses. We're going to go to part 2 next month, and I'm sure we'll have some more questions in part 2. We have speakers from the British Medical Association and also we're going to have some discussion around finance led by Peter Kay and Wrightington. So at that, I'm just going to say final thanks to everybody in the background from the National Orthopaedic Alliance, Claire and Anne and Fallon, for helping us organise these. I wish you all a very good afternoon, and I'm just going to close it there. So thank you again, everybody. Bye now.